All right, you guys. Good morning. Happy Saturday. I'm Dr. Malia Jensen. Welcome to Dr. J's Prescription for Health. So before we get started here today, I am live on Instagram and YouTube. Before we dive into today's topic, you've probably heard me talk about the medical buffoonery that we've all been fed for years. We've been bamboozled, and it's my mission to make sure that you never get bamboozled again. So to keep that mission front and center, I have developed a apparel line that you guys can check out. Maybe wear it at your next visit and let your doctor or your provider know that you are informed, you're doing your research, and you do not want to be bamboozled any longer. So I want to thank you for being here today, and it tells me that you are wanting to invest in your health, and I think that's really neat. So we're waiting for everybody to jump on here today. Our topic this morning is GLPs, GLP-1 agonists. All right, so looks like we're getting some people to come on, and we'll hang out here for just a second. This is your opportunity to ask questions, but at the very beginning of this live stream, I like to just share a topic. And today that topic is going to be on GLPs and weight loss. Well, GLPs and diabetes as well. So I like to talk about a subject, and then it encourages you guys to ask questions. And it doesn't necessarily have to be on GLPs, although I think that is going to be a topic that is gaining more and more traction. And we need to, I think we need to talk about it. All right. So GLPs first came on the market back in 2005. So it's been 21 years that these medications have been on the market. The debut was with a medication called Byetta, B-Y-E-T-T-A, Byetta, however you want to say it. But I think it is misleading to equate the early diabetes treatment, GLPs, with today's super drugs that are being used for weight loss. The drugs of the past, back in 2005, in fact, doctors rarely prescribe them any longer. They're rarely prescribing Byetta because there's new and improved medications, okay? So for the first 15 years, these meds were used at low doses to manage blood sugars and type 2 diabetes, okay? So 2005, Byetta. 2010, on the market, this was about the time I was transitioning from a corporate medicine to my own practice, center stage primary care. So I opened in and about 2012, and Victoza had come on the market around 2010. It was a daily injection of GLP-1 called liraglutide. Okay, Victoza. Victoza had a long ride, okay, and it really wasn't till 2017 when Ozempic came on the market. Ozempic is a long-acting GLP-1 called semaglutide or semaglutide. 2017 Ozempic semaglutide. So we went from 2005. We didn't get our next real GLP-1 until 2010. Then 2017 Ozempic. Then 2019 the oral version of semaglutide, of the oral version of Ozempic is Rybelsus. It was an oral version. 3 milligrams, I believe 7 milligrams, 14 milligrams. Thank you, Go Blue, you're right. They play today at noon Central. Thank you. So 2019, Rybelsus came out, oral version, had a little bit of side effects like nausea, and some people couldn't tolerate it, and they really didn't mind doing the once a week Ozempic, semaglutide, instead of doing the daily oral. Then after 2019, Rybelsus came on the market in 2021, Wegovy. Wegovy is basically high-dose Ozempic, high-dose semaglutide, and its indication was for weight management, okay? You know, I forgot something. I forgot Saxenda. I did. Okay, let me review just briefly, because I did forget Saxenda, and I don't want to leave that one out because it's part of the history. So 2005, as a review, 2005, Byetta. 2010, so we went 5 years, and we came out with, 2010 Victoza, trying to get then 2014 Saxenda. Saxenda was the first GLP-1 that was approved for weight management. So 2005, 2010, 2014, then 2017, the Ozempic, the once-a-week semaglutide for diabetes. 2019, the oral version of the Ozempic, diabetes. 2021, Wegovy, high-dose semaglutide, so high-dose Ozempic for weight management. Then in 2022, we got Mounjaro, which really isn't a GLP-1 specifically, it's a GLP-GIP, okay? And we can talk about that here in a second, which, what these, GLPs and GIPs and all that matters. But I'm just giving you a little bit of history. So in 2022, the first dual GLP, GIP came about. They're agonists, okay? And Mounjaro was that first dual medication. Then in 2023 came Zepbound, Zepbound, Zepbound. That's basically high-dose Mounjaro. These are weekly, but that Zepbound is for weight management only, where Mounjaro was indicated only for diabetes. So you can see where the pharmaceutical companies are playing these games. They come out with a diabetes medicine, and then basically they just change the name and change the dosing, and now it becomes weight management, okay? To give you a basic understanding of what these GLPs, GIPs is, first to look at what GLP is. It's glucagon-like peptide 1, glucagon-like peptide 1. It basically slows gastric emptying. It slows the transit time of your food going into the mouth, down into through the esophagus, and dumping into the stomach. Usually that takes time to, go through its digestion, and then it dumps into the small intestine and we get going. But these GLP-1s, agonists, will actually slow that dumping from the stomach. So you have food sitting in there for longer periods of time. Now, it can increase the risk of reflux, and we've talked about that, I believe, last Saturday. We talked about gastroesophageal reflux. And GLPs, or there's some other medicines, but GLPs actually can worsen that, all right? Now, a GLP can also tell the brain you're full. There's certain parts of our brain that these medications work on. They say, hey, brain, you're full. You don't need to tell the rest of your body you're hungry, okay? That's a mechanism. These GLPs also might trigger an insulin response when we eat. But honestly, I'm not sure that we have enough human studies that say that that's going on. I think in animals, GLPs can trigger an insulin response, meaning they'll tell the pancreas to increase secretion of insulin. Maybe not in humans. I don't know that. I don't think we know yet. So triggering. So in general, the GLP is like your brake, telling you to stop eating. But here's where things can go wrong, is that your body eventually tries to override. And when you override this not eating, so to speak, it will start leading to plateaus. Okay? Examples, I just named examples of GLPs are Ozempic or Victoza, Trulicity, Ozempic, Wegovy. Okay, those are the GLP-1s, examples of GLP-1s. GIP, like Mounjaro or Zepbound, they're GLP GIPs. So GIP stands for glucose dependent. So that's the G, glucose dependent, insulinotropic polypeptide, GIP. So the I is for insulinotropic and the P is polypeptide, okay? These GIPs work with GLPs, i.e. the Mounjaro and Zepbound, to help the body deal with sugar. There are also receptors for GIP in fat tissue, which is an interesting take. But GIPs have been shown to maybe buffer the amount of nausea that people get with a GLP. So if I was prescribing a GLP, like Ozempic, let's just make it simple. You have diabetes, I prescribed a GLP-1, like Ozempic, and a lot of times people get nausea. And that nausea usually shows up in the first 3 days of taking that medicine. Then the next 4 days, you don't have nausea. Then you inject it again and you get nausea for 3 or 4 days, then no nausea for 3 or 4 days. And bam, this cycle just keeps repeating. So when I sometimes would try switching these people, if their insurance paid for it, to Mounjaro, which is a GLP-GIP combination. And I noticed that people had less nausea. Now, if you didn't have nausea as a side effect, then I probably did not switch you. Unless, of course, you ask me, and, I'm all about being, a team member. And if you wanted to switch to Mounjaro because you heard that you can get more weight loss, I say, okay, let's just see if your insurance will pay for it. Bam. So we prescribe that. Now, there is another medication that's in the works. And so we have GLP-1 agonists, that's like Ozempic, Wegovy, okay? And then we have the GLP-GIP, that's like your Mounjaro and your Zepbound. Those are the combo GLP-GIP, so the dual. And now we have something called a triple G coming out. And it's by Lilly. I'm sure that Novo are going to come out with something as well, and probably already have it in the works. But a triple G is the GLP, the GIP, and a glucagon agonist. So the glucagon part of this triple G tells the liver to basically burn more energy, more sugar. That's what a glucagon agonist is going to say. Hey, liver, it's time to get burning here. So while the GLP and the GIP stop you from eating, the triple G part of this, the glucagon, is basically going to rev your engine. It's going to start burning. And with that being said, your heart rate can go up. And, for people who have problems with their heart, could bother or cause problems for cardiac pacing. Okay, so there's always negatives. Remember, the more G's you add, GIP, GLP, glucagon agonist, the more G's you have, the more risk of blowing the engine, okay? So yeah, the part of the car, the brake is the GLP, the stabilizers, the GIP, and the engine revving part of it is the glucagon agonist. So, we're doing all these, we add all these G's, and we could risk the engine, blowing. Okay. Something I also want to discuss is with GLPs, and this comes up because I think it's important that we understand how these medications work. And that's something called adaptation. In the lab, when we are studying these medications in the lab, the drugs bind to the receptors, and we watch what happens when the medications are binding to these receptors. But in a clinical setting, you guys, that's like you and me taking the medicine. We're not in a lab. There's no control. We're just out there taking the medicine. Eventually, we hit what we call a ceiling, a max dose. For instance, Wegovy max maintenance, FDA approved max maintenance is 2.4 milligrams. Zepbound is 15 milligrams. That is the max ceiling approved dose, okay? Why does a person start regaining weight while taking the medicine? Remember, in the lab, it's always hitting the receptor and it's always doing its thing. But in a clinical setting, the person is actually different than a lab. And over time, this person starts to regain their weight. That is not a drug failure. It's your body in survival mode, okay? The brain is saying, hey, there's not food coming in. Because when you take a GLP, GIP, triple G, your appetite goes down. It suppresses your appetite. Yet your brain needs nourishment, so to speak, okay? And not a lot of nourishment is coming in. So the brain tells or upregulates hunger hormones like ghrelin to be produced. Ghrelin I describe as gurgling. So when your stomach starts gurgling, ghrelin is starting to be produced, okay? That is going to when the brain upregulates ghrelin or tells the body to secrete ghrelin, it's also downregulating our resting energy expenditure. Okay, so what I mean by that, okay, if you start taking one of these medications, you eat less, your brain still needs nourishment, okay? Your brain still needs the nourishment, yet over time, it's going to tell the body they're hungry. That's where the ghrelin comes in. But also as a survival mode, we're going to shift into low gear. Well, maybe that's not. We're going to shift into survival mode. And that's going to lower your BMR. You could, because you don't have enough energy coming in. So you're not going to be burning as many calories. Does that make sense? If less is coming in, you're going to shut down over time. All right? Now, during this time that we are taking medications and you're losing weight, awesome story, right? That's an awesome, awesome story that you are losing weight. But the weight that is, when we talk about the weight loss, we have to talk about the quality of that weight loss. That is a concern, you guys. Because upwards, according to the step one data trial study, showed up to a 40% lean muscle mass loss. What that means is when you lose weight, let's just say you lost 100 pounds because I want to make this easy. If you lost 100 pounds, there's 40 pounds of that is loss muscle and loss of bone density, okay? That's really going to drop your BMR, your basal metabolic rate. You're not going to, when you are losing all of this muscle and you're losing bone, you are going to drop your BMR. You're not going to burn as much. That lowering of your BMR of 40 pounds or 40% of your lean muscle, you're going to be, at rest we burn a certain amount of calories. Well, the person who's lost 40% of their lean muscle mass is going to expend about 300 to 400 calories less. So if I'm sitting on a couch and my basal metabolic rate is this, you're sitting on the couch because you've lost a whole bunch of muscle mass. There's two me's, okay? I don't want to compare me to you. Let's just say there's two Dr. J's, and one is on the medicine and one is not, okay? The one that's on the medicine lost 40 pounds out of, they lost 100 pounds and 40 pounds of that was muscle. The person, the Dr. J that did not take the medicine is going to have just sitting there a basal metabolic rate that's 300 to 400 calories more burning. That's a lot, you guys. That's a real lot. Now, if you guys just hold the questions for now, and just know that, if you want your questions answered, put a Q in front of it, okay? And also, if you want your questions answered in higher order, if you want your questions answered right away, put it in a super chat. If you want to support this channel in general, do a super sticker, okay? So let's talk about the people who were on the GLP-1 or the GIP or combination, that's Mounjaro or Zepbound. If you stop the drug, data from the step 1 trial shows that 75% of the people quit in the first 2 years. That could be cost, it could be side effects, insurance, whatever it is. When you stop the medicine, your appetite's going to return. It's going to return to baseline for sure, if not higher appetite. But now you've lost 40% of your muscle, so you're not going to be burning. The result that we call this, from a medical terminology, we call it sarcopenic rebound. Sarcopenia means low muscle mass. So you get a rebound, and what the weight that you regain is fat. Okay? There was a recent e-clinical, and I did a thread on this, you guys. I posted this. There's an e-clinical medicine from the journal e-clinical medicine, did what we call a meta-regression analysis. So it looked back at studies. It did I don't know how many studies there were. It showed that patients regain an average of 60% of their weight lost in the first year of discontinuation. Again, going back to the 100 pounds lost. You took the medicine, you lost 100 pounds, you go off the medicine, and according to meta-analysis, patients regain 60 pounds more, they gain 60 pounds back in the first year after discontinuation. You lose 100, and in the first year, you gain back 60 of it. Now, something that the studies have not mentioned to my knowledge, this step 1, or even the SURMOUNT, is that the GLP-GIPs can actually have been shown, whether it's in humans or in the lab. I'd have to look more into this, but there are some studies that show that the GLP can increase fat cell hyperplasia, meaning that your fat cells are going to be replicating on this medication. Now, it's maybe not a bad thing that you have fat cells replicating. You might say, oh, Dr. Jensen, I don't think I want any more fat cells on my body. But if you have fat cell hyperplasia going on from taking this medication, because usually populations do not have fat cell hyperplasia. There are certain, cultures, let's just say white people. There are certain white people who have the ability to make more fat cells over time. Usually, that's not the case. So the people who have more ability to make fat cells can get super obese. I mean, the 400, 500, 600 pound people, they have in their genes, so to speak, fat cell hyperplasia. They grow more fat cells. Okay? I don't think the studies are talking about that enough, and doctors don't know about it, and they're not informing people. So if you do go off your medicine and you got more fat cells to fill up, you could get more obese than where you started. Okay? Again, I need to remind you guys that the regain, the 60 pounds. And you might say, yeah, but I lost 40. At least I lost 40. Okay. But you've left yourself, gladiator, in a metabolic mess. The metabolic mess is you lost 40 pounds of muscle, 40 pounds of bone density. So now when you do eat, and I guarantee you will gain it back, you have less muscle and less bone. Now, if gladiator doesn't mind having less muscle and less bone, hey, go for it. Get the 100 down, go off the medicine, regain 60 in the first year. I didn't say anything about year 2, year 3, year 4, I didn't say anything about that. Okay. The regain, it's important to realize or to take note of that it is not a failure of your willpower or even bad habits. Although I will tell you that most people who are on a GLP, GIP, and will be on the triple G do not change their diet, the things they're eating. They will continue to eat the exact same things that made them obese, yet when they go off them, they just ate less of them. And then when they go off the medication, they take the break away, it's all downhill. All right? Unless that person has learned to exercise and gain, muscle mass, has learned to increase their protein, has learned to lower the things that were causing the obesity in the first place, then, the metabolic mess will return, and it usually returns in the first 1 year, the most, obviously, and then the years following. So the way I look at it, and you guys can fight me on this, none of doctors or pharmaceutical companies are not curing obesity. We are basically facilitating a temporary weight shift. And this often will end in a worse metabolic state than when you started. That's what's really sad. And that's what, the human mind likes to attract itself to easy and joyful. And so if taking a medication is easy and joyful, they will avoid hard and painful at all costs. Yet when we think about ease and joy, we don't think about future. We think about the here and now. What makes me happy and joyful right now, that's easy. We don't think long term. And we also want to avoid pain and, hard things. Hard things would be like, okay, I'm going to change my lifestyle. I'm going to change my diet. I'm going to change my exercise routine. If I have one, I might have to start it. That is, the concerns that I fear, and I've been fearing this for the last, since when did I first started acknowledging that we have a definite problem? It wasn't during the Victoza era. It started, I think, with the Ozempic era, where I was constantly seeing Ozempic, and I couldn't figure it out. I actually thought maybe the person wasn't dosing themselves because of the side effects, but I don't think that's true. And speaking of side effects, let's go through those. The side effects of the GLPs. Are you guys on it? Are you guys on a GLP right now? And if yes, did your doctor tell you about side effects? Oh, you could get nauseated. Okay, well, that doesn't seem like it could be that much of a problem. If I'm nauseated, I'm just not going to eat, and that's a great thing, right? Okay, but what about worst case scenario? Hold, please. What about worst case scenario is you get a condition called gastroparesis, where basically that is a stomach paralysis. Your stomach is already in a position of slowed gastric emptying, okay? But what if the GLP receptors actually cause a paralysis of the stomach? You're not going to get any dumping. That's called gastroparesis. And there are safety warnings to stop a GLP prior to surgery. So your stomach actually needs to be empty about 2 weeks prior to starting a surgery. Please note, if you're on a GLP and you are going to surgery, like a hip replacement or a hernia repair or whatever it is, stop the medication 2 weeks, for 2 weeks prior to your surgery. Or you could get aspiration. So that, and it can, when you lie down, it can cause reflux. Well, this is worst case scenarios. You're lying down, you're in surgery, and you get an aspiration pneumonia. So besides the side effect of gastroparesis, there's decreased bone density. Why is that? Well, when you're on a GLP or a GLP-GIP, you get rapid weight loss. But with that rapid weight loss, guess what? Bone mineral density goes down, upwards to 3 to 5%. And you go, oh, that's not much. When it comes to your bone, losing 5% of your bone mineral density, and that's just in 1 year. By the time 5 years rolls around, 30% of you will have osteoporosis. That means high risk for fractures. So, side effects of GLP, GIPs, gastroparesis, decreased bone density, decreased muscle mass, I spoke of before, sarcopenia. There's also a condition of the eyes, increasing your risk of what we call eye strokes. Okay? The mnemonic for that is NAION, basically an eye stroke, a sudden permanent blindness. When you are on a GLP, you are 4 to 7 times more likely to get this eye stroke. Again, you say 4 to 7%, I'm willing to take my chances to lose weight. Okay. How about this one? Death. In the latter part of 2025, the FDA issued a warning letter to one of the major companies of GLPs because they were failing to report side effects, serious side effects, and deaths in a timely manner. So they could say, oh, I've kind of heard that some people are dying. Well, let's look into this. And it takes a year, maybe even 2 years, and they weren't documenting anything because they're looking into it. So the FDA issues a warning letter to say, get off your butt, enter this stuff. See, the manufacturer didn't enter the data because, well, they don't want people hearing that people are dying or having serious side effects like gastroparesis or osteoporosis, because how can you really prove the osteoporosis? You're getting older, you eat crapola. I mean, how can you really prove that? But correlation to gastroparesis and taking a GLP, GIP seems a little more, I guess it would maybe correlate and for causation. But, I guess I just think that we if you want, you can take your chances, that's I guess that's what I'm trying to say. There are studies out there, and I don't think doctors are even reading them. I don't know that I read them. Okay. Sharon asks, what about constipation it gives? Yeah, it can cause constipation because you're getting slowing of gastric emptying. So yeah, everywhere in the bowel is slowing down. There's GLP receptors all over in the bowel. Okay. Okay. If you guys have a question, put a Q in front of it so I can recognize it. I don't think I have any Blue Shields moderators here with me today. Okay. Let's see. Trying to read through. If you guys got a question, let me know. I mean, we talked about a lot. on the GLP, the history of the GLP, and then the history. Oh, that's a good point. Metabolism IQ. When I mentioned about the 40% loss of muscle mass, as a reminder, heart is also a muscle. So you're causing atrophy or sarcopenia of all muscles, not just the skeletal muscles that we think about, but what about the heart? So you could be increasing your risk of congestive heart failure, all right? That is a strong possibility. So we have to be taking into consideration all the muscle in our body, all of the sarcopenia that's going on. Another thing that metabolism IQ brings up is that the GLP receptors could shrink. And that actually has to do a little bit with a concept that we call tachyphylaxis, where, picture this, let me give you an example. If you take Benadryl to sleep, in the first week, you take the Benadryl, you're knocked out, you're sleeping like a dream. But by week 2 or 3, the Benadryl is not working. So you take double dose of Benadryl and you get another effect. But what's happening is the receptors are actually downloading, okay? So you're taking more medicine. Or at first you had, let's just say you had 10 receptors. You took Benadryl and the Benadryl stimulated all 10 receptors, okay? Over time of taking this, say 2 weeks, now the amount of receptors available to be stimulated is 5. So now you have to take more medicine to hit the 5 receptors. They're down regulating. If you were to stop the Benadryl, allow a month to occur, to go by, now the receptors upregulate again. You give the small dose of Benadryl, it starts working again. It is possible that is happening with GLP as well. But most of the rebound or most of the eating through the things is occurring in the brain, in the reward center, the mesolimbic system, where we are hearing food noise. And that food noise is not just hunger, it's actually food cue. If the GLP is working on the brain's reward center, like the nucleus accumbens or the ventral tegmental area, I believe that's what it's called, and it's dampening the dopamine signal, okay? That's what a GLP does at first. It's going to dampen the signal, and so you feel less hungry. But over time, the brain, because it's in survival mode, is going to turn that off. At first, food's not compelling, but the brain is still recognizing food. It just stops obsessing. But when we start hitting that plateau, that's where those other studies came in, not just step 1, but the SURMOUNT studies, SURMOUNT 1, SURMOUNT 4. They came in and said, hey, the body's hunger signal, because of the brain, is going to start stimulating ghrelin, the gurgling hunger hormone. That's why we get this trickle effect. And that's why companies like Novo and Lilly are making higher supercharged doses. If it was Ozempic, the max was, I guess the Wegovy, it's 2.4. So once you reach 2.4 milligrams of Wegovy, which is 2.4 milligrams of Ozempic, which is 2.4 milligrams of semaglutide, or 15 milligrams of Mounjaro, which is Zepbound, you can see that we have no more doses. And if they do come out with a dose, like let's say Zepbound comes out with a 20 milligram and Wegovy comes out with 3.2 or 3.6, okay? There's no studies on these medicines, you guys. You are the study. You are the, basically the guinea pig. And what I get as kickback or to defend this, and they'll say, no, we have 20 years. The GLPs have been out for 20 years. No. Yes, they have been out for 20 years, Byetta, 2005. But those were in tiny little doses and used only for diabetes, for blood sugar control. We are turning this into something turbocharged, you guys. And you're the guinea pig to the turbocharging. And so when you start eating past Zepbound 15 milligrams, and you might maybe even start dosing a little bit more yourself, okay? You want to try it. You are basically increasing your risks. You could increase your risk of death. I'm just not convinced that the doctors are sharing all of this with you, okay? Yeah, Paul, they do. Paul mentions, I heard these drugs, GLP, GIP, cause people, or not cause, but maybe allow people to stop smoking or gambling. Why? Because of the mesolimbic system in our brain, where dopamine is. If the drug is curbing our appetite, what if the same receptors for gambling, or basically I'm talking about dopamine, Paul, if the GLP is lowering or not signaling the dopamine hit for eating, it's also going to help not trigger the dopamine hit for smoking and gambling. But again, a survival mechanism will start kicking in eventually. You can't just shut down the amount of calories coming in. You are going to lose muscle. You're going to shut down your basal metabolic rate. You are going to be nutritionally deprived, so you'll be malnourished. People who are on these medications at high doses are malnourished. Oh, how can I be malnourished? I'm still obese. You can be malnourished and obese at the same time because of the foods you're taking in. One, they might be 500 calories a day, and those 500 calories might be a box of tamales or a Snickers bar. There's no nutrition. So you are causing bone destruction, you're causing muscle destruction, you're causing, your body's just shutting down just because you want to lose weight. So you have to think to yourself, is it worth this weight loss? That you cause a metabolic mess throughout your whole body. You increase your risk of heart attacks, you increase your risk of eye strokes or strokes anywhere, really. Okay? Because if it's happening in your eyes, microvasculature, what's it doing to the macrovasculature? Lion asks, do I know if doctors receive a bonus from pharma for prescribing these? To my knowledge, no. The answer is no. Now, if I am a speaker, if I'm a speaker for Novo or a speaker for Lilly, where I'm hired to go to and lecture to other doctors at some dinner program. It's called a dinner program, okay? So I travel, 50 miles down the road and I lecture to somebody at some steakhouse. I even if it was one doctor I lectured to, I will get paid. My slides are pharma sponsored, so they give you the slides and then you go through them. And I could get paid anywhere from $1,000 to $5,000. It depends on what they want to pay me. And if I decide, nah, you know what, that's not worth it to me. How about $5,000? Okay, you're a really good speaker and you're a really good teacher. Okay, so I can get paid. But if I get paid, I'm also, I'm responsible for the taxes. So, at the tax rate of most doctors, you're looking at upwards to 47%. So the $1,000 turns into $500. That it would be considered my bonus, but it's really just a job on the side, okay? Make some extra cash. If I write 50 scripts of a GLP every month, will the reps be coming into my door and telling me how great I am? Absolutely. They might not say, thank you for writing my product. They're going to say, how's your patients doing? Are they losing weight? How's their diabetes? And I will say they use techniques that butter us up that will continue our prescribing habits. Now, they're the ones actually getting the bonus. They're counted overall by how many scripts, not usually by one particular doctor. If Dr. Jensen is writing 50 scripts a day, they're getting their whole region. So if they want to have 10 Dr. J's writing 50 scripts a month, okay? If their region is only seeing 10 scripts a month, their chance of getting a bonus at the end of the year is not as good, okay? And sometimes the reps are limited by their region. So they bang extra hard on the doctors who are writing it, okay? Now, the reps or the company doesn't say, Dr. Jensen, psst, 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 thank you for writing those 50 scripts a day. Here's $1,000. Now, nope. Okay, not happening. Unless you guys know something that's being done under the table, but that is so illegal. Oh my gosh, there's a lot of people that'd be going to jail. Okay. Pharma reps should be illegal. It makes it easy for a drug rep, a pharma company, to educate doctors, makes them lazy to actually read the studies. Bias gets missed. Well, I could go both ways on that, metabolism IQ. For me, I felt like I was rewarded when they came in. Why? Because I like to learn. And I probably did not have time. I wouldn't say I was lazy, but let's just say I'm working 10 hours a day. I got to do my clickety-clack work. Then I got to go home and take my kids to their practice and their outings, or I want to go out to dinner with the husband or do whatever I got to do, okay? Those are the things I got to do. So I wouldn't necessarily say I was lazy. I would say that I choose not to put into my daytime routine because I'm at work, I do the thing, and then I go home and do the home thing. And not all of us doctors are very good at reading studies. We can read the abstract, we can do all of these things, but for the most part, we are being educated on studies that I think are fake and fraudulent anyway. And we're being tested on them, like this continuing medical education that we do. Continuing medical education is underwritten by the pharma companies. So everything that we are getting continued medical education on, which is required, it isn't the ones where it's talking about a ketogenic diet, reversing diabetes and obesity. No, there's not going to be any studies or any CME on that. There are now at CME.com, I believe it is, they are actually starting to have doctors enter into studies and CME educating doctors on ketogenic diets or ketosis in general and what it means. Okay, so I hear what you're saying, metabolism IQ. Even if the reps didn't come in, I would venture to guess that the doctors aren't going to read the studies you want them to read anyway. There's just not enough time in their day. Okay, I don't think it has anything to do with the pharma reps, but for me, I like to be educated, and if you want to buy me a cup of coffee to educate me, eventually, I think they will start to sense my antagonism, because they educated me in the first, and then I took it and ran with it. And so then I started to really question them. And then I found out just how little they're being told, okay? They're being told talking points to get the doctor to write the product and show you results. And usually it is relative risk reduction, not absolute risk reduction, which looks like less than 1% benefits of this medication, where the relative risk could have shown, oh my gosh, doctor, 40% relative risk reduction of blah, 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 when you take our medication. Huh? There was a time I was bamboozled by all of these things. I agree, okay? But now, no, I'm just trying not to be bamboozled. And that's my mission for you guys, is to no longer be bamboozled by this buffoonery, okay? Yeah, metabolism IQ makes a good point. The pharma reps will not only just call on the doctors, but they will call on the pharmacies, okay? They will call on the pharmacists and teach the pharmacists how to get these claims paid, which is, I mean, These pharma reps work hard. Don't get me wrong. You think they're just kind of lounging around? Most of them, okay? The people that I know are not just lounging around. They're making calls. They're doing this. They are trying to get these scripts to go through. The doctor writes it. They got to now follow up at the pharmacy and make sure that the pharmacist knows how to run the codes. What if there's a coupon card, a $0 copay? So the pharma reps head over to the pharmacies, teach the pharmacist how to run the code in order to get that medicine paid for. That sounds like a wonderful thing that they're doing, but who pays in the end for the $0 copay? The answer is taxpayers, okay? If you're a taxpayer, you're paying for your neighbor to take Ozempic. It's not just like a direct thing, but it is down the line. You are the payer. So when the pharmacy companies say, oh, it's $1,000 a month if you pay out of pocket. Well, they say, no, I got insurance. Your insurance rates are going up. How many look at your insurance rates. Every year your premium goes up. I mean, it's crazy when somebody says, oh, it's free, it's $0. No, it's not. It's not. I'm sorry. Let's see. That's interesting. Metabolism IQ was doing some CME, so continuing medical education, and nutrition for pregnancy, and nutrition or just on a CME on cholesterol. And the first things that they mentioned is their propaganda. The propaganda is the first thing they're going to mention in pregnancy is make sure that the pregnant patient is taking their iron supplementation, which is after you've really learned things, you're going to know that taking an iron supplement is not in their best interest. But until you really know why taking an iron supplement is not in your best interest, it's something you have to go down a lot of rabbit holes, like maybe a year's worth of rabbit holes to understand why they want to promote one, hey, yeah, it's okay if you get pregnant. And no, you don't have to be married. And no, you don't have to believe in God. And here's your iron supplement, right? Okay. And as far as statins are concerned, that's the same old indoctrination that LDL is the cause of your heart attack. Okay. If you have a cholesterol it's elevated, here's your statin, and you're going to have a less risk of having a heart attack. So that's what we learn in CME. So if all the doctors are getting told through guidelines, we follow recipes, by the way. They're called guidelines. Okay. And then they do CME and they're being told the exact same thing. You can see where it's feeding the experience that the doctor has. And the doctor has a cup full of experiences, and then they work on a recipe. They work on guidelines. They work on just not looking outside the box. As long as they're following guidelines, there's no risk of getting sued. Okay? If they start stepping outside of the guidelines and start using their own brain, that means they're dissenting. They are dissenters, right? They've gotten out of the tribe. They were radically divided, right? Between the LDLers causing heart disease and the non-LDLers causing heart disease. Now you've caused division. So the non-LDLers are now dissenters. They've left. Now they are at risk, very high risk of getting sued or being taken to the board and put back in place. Doctor, we have heard, we have seen that you are not following guidelines. You either follow guidelines or you could lose your license. And then they'll say, because you don't know anything, you dissented, you don't know, they're gonna send you to a course. They require you to take a course to re-educate you. And then you have to go to the course and then write a summary of what you learned. And by the way, the dissenter actually has to pay for everything out of their own pocket. They have to pay for the course, which could be $1,000. Then the stay for 2 or 3 days, that's another $1,000 or $2,000. So that by the time you go on your vacation to your course that the board required you to go to and told you how bad you are, made you feel like a shameful idiot, do you think that the doctor is going to want to do that again? Nope. they'll go back to following the guidelines. So what should you guys do? What should you guys do? Because I know the answer. The answer is looking back at you in the mirror. It's you being your own doctor, educating yourself. You probably have more time in your hands than the doctor who's working the 10 hours a day, doing the clickety-clack on the charts to get paid, and then going out to eat or going to their kids' events. You might have a little bit more time, like maybe an hour or two a day, that you can educate yourself to be your own doctor. Now, if you get your finger cut off, I would recommend that you go to the emergency room and get your finger stitched back on. But there are times and places for doctors, and maybe, once you jump out of the matrix, you are more educated than a doctor. It is what it is. They only taught us certain things that they need us to know in order to perform the machine. The machine will work as long as all of the little minions are following the rules. Okay? Right. Yeah, that's a great point, and that's something I brought up. When the reps come in, the original statins, so say Lipitor or Crestor or something like that, they would tell us that there's a 40% there was a 40% risk reduction. What they didn't tell us, because doctors wouldn't ask, they wouldn't even know what to ask, trust me. They didn't know that that was actually relative risk reduction, where the absolute risk reduction was never told to us, and it was usually less than 1% absolute risk reduction. So that's how they tricked us. I mean, and they didn't even really trick us. They just didn't provide us with all the information. I think it's called selective informants. There's selective informants. And I was faked out. Hi, Penny. Okay. Let's see. Put a Q in front of your question if you have one. What does the FDA say about GLPs for weight loss? Well, how does the FDA go on year after year after year? How does any three-letter agency go on year after year after year? Notice I said the FDA sent the company a warning letter. Please start documenting deaths and serious side effects. A warning letter. And we go, you go good FDA, you're protecting us. Oh, look at who their sponsorship is coming from. All the three-letter agencies, you guys. This is all one big giant rabbit hole. It really is. They're all in bed together, Shoulda Wave says, just eat real food and learn how to do that one day at a time. Problem solved. No guinea pig Band-Aids. Yeah, unadulterated food. Correction, unadulterated food. Just eat real unadulterated food. Okay. Robert, you're very welcome. Thanks for being here. I appreciate you. Slick Rick, I doubt it. I doubt that is going to be an attendee of anything. So I don't know. Let's see. Jack says a carnivore for 5+ years. So carnivore means 0 carbs. Triglyceride to HDL ratio is 0.6. Carnivore for the win. Good job, Jack. Thanks for sharing that. That was a metabolism IQ. That's a great side effect. I did not have that in my memory bank. Yes, there is a black box warning for medullary thyroid cancer if you're taking a GLP. Did your doctor tell you that there's an increased risk of thyroid cancer by taking a GLP? Likely not. But usually the pharmacist will tell you You'll go to the pharmacist, you'll pick up your thing, and they got it locked in their head. Hey, you don't have a risk of getting any thyroid cancers, do you? Or family history of thyroid cancers? And you go, well, yeah, matter of fact, my mom did have a thyroid cancer. And then the pharmacist is supposed to say, you know what? I don't think that you should buy this drug right now. You need to go back and talk to your doctor. And so can the pharmacist override the doctor's prescription? Absolutely, right? They're trying to protect the patient. They're trying to protect the patient as they're getting their kickbacks from the pharmaceutical companies, right? The pharma has kickbacks, or I don't want to say kickbacks, but they have incentives for the pharmacies to fill the prescriptions. But there's some pharmacists who are just, they have ethics. And those ethics will say, hey, did you have a family history of thyroid cancer? And they say, yeah. Well, I think you should go back and talk to your doctor. And until then, we'll just put this back on the shelf. Don't you agree that we should just put it back on the shelf? Oh my gosh, I didn't know. Patient says, I didn't know. I'm so glad you told me, Mr. and Mrs. Pharmacist. Thank you so much. How come my doctor didn't say that? You go back to your doctor and they'll say, you know what? The relative risk reduction, or the relative risk of you having a thyroid cancer is like blah, blah, blah. And you go, oh, okay, doctor knows all. The pharmacist is dumb. You see how it's so great, this triangulation that goes on. That's called triangulation, you guys, when they pit each other against one another. And then the doctors hate the pharmacists, and the pharmacists hate the doctors, and then the patient is in between. I like my doctor, my pharmacist is so great, they fill my scripts ahead of time, they just do whatever I like. I mean, it's crazy, the triangulation that goes on. Okay. What insurance company pays for these things? I knew someone that said they were paying $1,000 per week to take this GLP. Do insurance companies pay? No, but you can get in studies. So a patient or a client or a person, a citizen, can get in a study. And that is sponsored by a pharmaceutical company, and usually a third-party pharmaceutical company. Or a third-party group that holds a study that says, hey, do you want to enter? And they talk to the doctors. Hey, doctor, do you have 5 patients that you can enter into this study? We'll give them free GLP. We'll do this and that. Insurance is not even in the know. No one knows. The insurance companies do not know these things. Now, insurance companies save money because the pharmaceutical company will pay the insurance companies. Usually, they'll tell you, we don't pay. Sure you do. You lobby the insurance companies. Pharma lobbies the insurance companies, and they say, put our medicine on formulary. If you put it on formulary, then you're going to get some incentives. Triangulation. It's one big happy marriage, and you are the pawn as the patient. You could just put your middle name to pawn. Sally Pawn Jacobson. No, it's Sally Ann. No, it's Sally Pawn. You're a pawn. And it's not just in the medical system, you guys. It's all over. We got to start opening our eyes and learning that we're in the last days and it's going to get worse. It will get worse. Yeah, should have waived. It's $1,000 a month and they've actually lowered it. They're lowering it now. If you pay cash, did you know that 30% of the scripts written now, 30% do not go through insurance? They actually go through self-pay. The patient will self-pay. It used to be $1,000. Now they're lowering it to like $300-$400, but the reps or the pharma company actually get more bonuses by not going through the insurance company. So if a doctor convinces the patient to pay, you know what, just forget these insurance companies. They're just trying to rule everything. Just pay out of pocket. The reps or the pharma company actually gets more for you paying out of pocket. Now, what's happening is companies are being developed that will do compounding. They will buy the base chemical, semaglutide, right? And they will compound it and it'll make it just a little different. They'll put some vitamin C in it or something where now it's not the true Ozempic, it's something they made in a lab. They compounded it. They bought chemical from China or New Zealand or wherever, America, and then they compounded it in their lab and they sold it to the people for $200 a month. Now, did that piss off the pharma companies? Heck yeah. So they took them to court and said, their compounded medicine looks just like ours. So then the FDA gets involved and shuts those compounders down, or the places that are compounding, like spas. So you can go to your local spa where you get tanning and massages and this, and then in the corner, they have a little chair and you can get an IV of your little cocktail and they'll say, gosh, you're overweight. How about some cocktail of some injections once a week? You mean I don't have to go to my doctor? No, not at all. In fact, you can just buy it online through Hims or Hers or wherever, Row, wherever you want to go, all compounded. Okay. Good, New Way. That's awesome. You're such a generous person. Ohio says, can you eat eggs and dairy on a carnivore diet? Well, you can eat it on a carnivore diet, but it's not a carnivore diet. So yes, you can eat eggs on a carnivore diet. Is that considered a carnivore diet? Eggs? Yes, because there's no carbs or very little, just like a piece of steak. Now, dairy, on the other hand, has a lot of lactose, has sugar. So is dairy considered carnivore? No, because carnivore is zero carbs. But if you, Ohio, want to eat eggs and dairy, just say, I'm going to eat eggs and dairy with my other animal products. And it might not technically be called carnivore, but at least it's ketogenic. I'm ketovore. Okay. Sales and science are a bad combination because they're one and the same. I have no idea about the strongly worded, if it was strongly worded by the FDA in the report, who knows, but that's what they'll say. It was strongly worded and strongly encouraged that this company starts documenting all of the deaths and serious side effects. And then they tell the public that they did it. They actually have to announce that they did it to make themselves look good. What technique is that called? That is a technique where you say all the right things to get the people to think that you're just all on their side. What a freaking joke, you guys. It's a joke. Let's see. Just the facts. I do not know anything about those two things that I would have to look it up. So Rob says, well, there's black box warnings on SSRIs for suicidal ideation, but they are, as in the SSRIs, are still the best. Rob thinks that SSRIs are the best thing we've got for depression. The risk is small. A black box warning needs a lot of context. So Rob appears to be defending medications. So if it happens to Rob himself or Rob's family member, then they get upset. But in general, if a person on an SSRI commits suicide, it was not the SSRI's fault. It was that the person just went down. And they were down and they committed suicide. So it never really gets back that it was the SSRI. It was just that they were so sad and blue. And we never looked into anything else. Rob, do you think that the doctors are actually looking into the real cause of the depression? Likely not. They're seeing 40 patients a day. They're not going to say, well, what's got you down? Let's talk about it. And unpeel the onion, the layers. And so if Rob wants to say N of 1, it's the best thing that's ever happened, and says the risk is small, some other 10,000 people don't want to take the small risk, which I agree. And were they informed? When you guys went and got your SSRI, did the doctor say, hey, there's a small risk, there's a small risk of committing suicide on these medications? No. And if they did, they probably said it underneath their breath with their head down because they want you out of the office. Or better yet, let's just send you to a psychiatrist. And then the psychiatrist, here's the psychiatrist. Sounds like that you're having some problems with the, okay. Are you suicidal? Have you thought about suicide in the past 1 to 2 weeks? Oh, okay, good. Okay, good. Okay. And are you taking your medications? Oh, okay, good. Okay, great. Okay. And have you been getting out and doing something? Oh, good. And then the person's sitting there. Don't worry, I've seen this happen. I've been in the rooms watching patients with a psychiatrist, so I know exactly what's happening, okay? All right, and so they go through these things, and then then the patient goes, or the doctor says, so it sounds like you're doing pretty good, and the patient's going, yeah, but I'm kind of depressed, but they don't want to tell anybody, tell the doctor, because, well, the doctor just went through and well, I'm not really suicidal in the last 2 weeks, but in 2 weeks and plus 1 day I was, but it was nothing. And if there was something, then the psychiatrist is going to say, you know what, you need to go to therapy, which honestly, that cognitive behavioral training or whatever they call it, and EMDR and CPT, cognitive processing therapy, yeah, all of that might be the best. Why would you put a chemical in your body? Remember, all of the things we're eating and breathing in and drinking in our water and all of these environmental things could be messing up your body. And then you take an SSRI, which is basically just shooting you full of some serotonin agonists, and you call it the best thing and nothing else was changed. And so the best thing that you could have done is likely go to therapy and walk through the things. Unpeel the onion instead of just jumping to a medication. Ask yourself, and I mean, I know I've had a clinical practice, 1 out of 100 people is going to therapy. It's a little more prevalent now. And do you think that patients are going to ask their doctor, hey, doctor, can you refer me to therapy? And then you're going to think that the doctor thinks that you're crazy. And so you don't tell your own doctor that you're going crazy because they're going to think that you're suicidal. And then they're going to call DHS on you or whatever they do. Call the family member, do the thing, or just say, hey, I'm just going to refer you because I want to kick you down the street. I don't really want the risk that you could actually commit suicide tomorrow. I think I'm just going to refer you. No, my hands are clean. My hands are clean. But I really care about you. So I'm going to send you to the psychiatrist. This guy. So you get in at 2 weeks down the road, or 3 weeks down the road. And have you been suicidal for the past 2 weeks? Oh, good. Okay, no, okay, good. Okay. And have you been taking your medications? Okay. Oh, good. Yeah. Exactly. We're bamboozled to think that we can just hey, and you know what? Here's the thing. If Rob says the SSRI is the best thing for his depression, oh my gosh. That's a win, you guys. It's a win. A win. Just like the Ozempic. You lost 100 pounds? It's a win, right? It's a win. But what is it doing to your system? Are the risks for SSRIs for cognitive decline over time? Is that a risk? Yes. Is there a risk that it messes you up metabolically? Absolutely. Same with the Ozempic. Was that told to the people who are getting the SSRIs? You got depression, you get an antidepressant. You got high blood pressure, you get an antihypertensive. You get obesity medicine, you get the GLP. But a lot of people have been bamboozled. There's nothing else. You have to be that person. You are absolutely, your body is deficient of an SSRI. Just like you're deficient of a GLP, and you're deficient of statins, and you're deficient of ACE inhibitors and beta blockers. Metabolism IQ says that depression is energy nutrient problem before it's a serotonin problem. Why is serotonin not working very well? What part of our brain and our gut? Remember, where all the many, if not most, of the serotonin receptors, where are they located at? The gut. The gut. What is wrong with your gut? Well, it's inflamed. It's leaky. I'm eating crapola. I'm eating gluten. I'm eating plants. The plants are causing inflammation in your body, in your gut. The gut lining becomes inflamed and irritated. The gap junctions they're not tight, they're loose, where the cells come together, they're supposed to be tight, but now we got gap junctions, things leak out, we get all over body inflammation, all over body oxidation, all over body mess up, just because of our gut. It's not a serotonin thing just in our brain. Just the fact says the insurance company does pay in some cases. It does, but look for a pay hike on your premiums next year. (1910) says perhaps doctors are indeed hesitant, but the patients are insistent. They are, trust me, about being prescribed the GLP. Doctors might not want to start a fight with their overweight patient who has not followed the program. You are exactly right, 1910. And so doctors have no boundaries. They have no boundaries. They can't say no. They're people pleasers, many of them, others not so much. But that particular doctor is a people pleaser, does not like conflict. And they will say, as long, 1910 says, you can either take it one of two ways. I'm going to give you informed consent. I'm going to tell you about the loss of muscle mass, the loss of bone mass. I'm going to tell you about the eye strokes. I'm going to talk about the gastric paresis. I'm going to tell you all of those things. I'm going to have you sign up a form. I'm going to put it in your chart. And if you still want the medication, you are on your own, you're on borrowed time. Or the doctor could set a boundary and say, no, you are a risk for this particular medicine, and I do not feel comfortable writing it. And then that patient will leave that practice and go to the next one or buy it online. Okay. Trying to look for questions, you guys. NJ says, what happens to your system? What happens to your system with acid blockers, like for the digestive system? Well, we went in, and you can check out my live stream from last weekend. I believe it was on Saturday, or it was the Saturday before. It was on a Saturday, I do know that. And I talked about GERD, and I talked about PPIs. I talked about PPIs, proton pump inhibitors, lowering stomach acid, okay? Normal stomach acid is between 1 and 3. When the acid is like that, 1 to 3, we're able to absorb nutrients like B vitamins and calcium and magnesium and selenium and zinc and amino acids. Did I say that one? So we are able to absorb our nutrients at that stomach acid. If we take a PPI, we change the stomach acid acidity to, say, 4 or 5 or even 6. Now we can't absorb our nutrients. Can we get malnourished? Absolutely. So if you aren't taking in amino acids, that's your protein to make strong bones and teeth and muscles, then, your amino acids are low. What about calcium and magnesium and zinc and selenium and an iron? We need iron for our brain. So all of these things we're not going to absorb because the stomach acid has changed. We also increase our risk of, when we lower the acid, we can increase the risk of gastrin being secreted. When gastrin is secreted, to try to change the acidity, we're at risk for high parathyroidism. So parathyroids sit here. So we probably want to check a PTH because we could induce people getting hyperparathyroidism by putting them on a PPI. Well, how do you know if you got a parathyroid tumor or a parathyroid problem? Well, the doctor should be looking at the calcium level on your CMP, complete metabolic profile. Look at your calcium level.